Next, let's discuss assessment of pituitary gland function. So the test to determine pituitary function should be relatively easy to remember. For the anterior pituitary hormones, there are assays to measure each and every one of these hormones. And the trick lies in knowing how to interpret them because the levels can vary based on the time of day and many other factors that you'll learn about in later sessions. So typically, the end organ analytes also have to be measured in conjunction with the pituitary hormone. Otherwise, they're really difficult to interpret. So to diagnose a posterior pituitary problem, we do rely more on the end effect analytes rather than actually measuring antidiuretic hormone or ADH. And the end effect analytes include sodium and osmolality in both in the serum and the urine samples. And so details on the posterior pituitary will be covered later on. But now let's focus specifically on testing of growth hormone and its adequacy or excess because it has several nuances that are unique. So many different factors affect growth hormone levels in normal individuals and on a daily basis. So here's a basic cartoon with the hypothalamic pituitary axis that we've reviewed earlier. And so stimulating factors for growth hormone are shown on the right, and they include deep sleep and stress and exercise, low blood sugar, and other factors. And so on the left side are these inhibitory factors for growth hormone in normal individuals, things like malnutrition and illness, hyperglycemia or elevated levels of blood sugar, and again, several other factors. So when diagnosing growth hormone excess and deficiency, it's important to be careful about the conditions in which growth hormone and IGF are being measured. The other thing that can confound measurement of growth hormone, besides all the inhibiting and stimulatory factors we just saw, is that growth hormone secretion is episodic. And so there's a graph here on the right to demonstrate that, where growth hormone is represented by the red line, and on a basal or regular basis, growth hormone levels tend to be low, and they can be released far more in conditions such as sleep. On the other hand, the intermediary that growth hormone stimulates from the liver, IGF, has a longer half-life, and as a result, it better reflects the overall growth hormone during the day. And IGF-BP3 stands for IGF binding protein, and together with IGF, it forms a complex and also has a more stable half-life. So based on the properties we just discussed, it makes sense that when you're screening individuals for growth hormone excess or acromegaly in adults and gigantism in kids, you would first measure IGF-1, again because of its stability and its longer half-life. So levels that are above the reference range should at least suggest that the patient has a growth hormone excess, and then confirmation has to be performed. And for confirmation, that happens by administering an oral glucose load and then measuring serial growth hormone levels over time. So in a typical response, when the blood sugar is raised by an oral glucose load, the growth hormone should decline, and that's represented by the blue line here, where you see by 1 hour and certainly by 2 hours. There's no growth hormone left because of the high blood sugar that's been induced by the oral glucose ingestion. In patients with acromegaly or growth hormone secreting tumors, no matter how much glucose is ingested, the growth hormone doesn't respond. So the abnormal line is here in red, and that represents an abnormal response to glucose load, meaning there's no evidence of growth hormone suppression, and that's generally confirmatory for acromegaly. On the opposite end of the spectrum is diagnosing growth hormone deficiency, and so here too, IGF-1 is a good screening tool either alone or in combination with its binding protein, IGF-BP3. So low levels of IGF-1, often under 2.5 percentile for age, suggests deficiency. But false results can occur. So patients with partial deficiency may have falsely normal results. Or patients with malnutrition, for example, may have falsely low results. So to confirm growth hormone deficiency, generally a stimulus has to be administered to see if growth hormone levels rise appropriately. And there are many different stimuli that can be used. The gold standard is to administer insulin, which causes the patient to become hypoglycemic. In a patient with a normal response, insulin, for example, would stimulate quite a rise in growth hormone, which is shown by this blue line. But in an abnormal response, no matter what the stimulus, whether it's a hypoglycemia induced by insulin or giving a peptide called arginine, the growth hormone will not rise, and that's this red line, and it represents a patient with growth hormone deficiency. And a critical concept in diagnosing pituitary disorders and interpreting pituitary labs is the importance of distinguishing between a primary and a secondary disorder. So a primary disorder refers to the endocrine gland itself being dysfunctional. So this means that the gland is autonomously secreting too much hormone on its own, or it's failing and is unable to secrete hormone. While a secondary disorder refers to the endocrine gland itself being fine, but the problem is that it's receiving too much or too little trophic hormone from the pituitary. So the problem is in fact secondary to a pituitary problem rather than a problem in the end organ itself. This table summarizes how to tell primary disorders from secondary disorders, and the most important thing is to remember to never try and interpret pituitary hormone levels in isolation. So you always have to look at both the endocrine gland hormone as well as the pituitary hormone itself. And so these first two rows shows what happens in cases of hyperfunction, and it would make sense that the endocrine gland secretory hormone, for example, thyroid hormone or adrenal hormone like cortisol, should be elevated anytime you use the word hyperfunction. If it's a primary hyperfunction where the gland itself has become autonomously functioning, there will be high endocrine gland secretory hormone, but low levels of pituitary hormone because of the feedback loop. In this case, when the gland becomes autonomously overactive, the pituitary knows there's no reason for it to continually secrete a releasing or a stimulatory factor, so the pituitary hormone's low. But in contrast, if it's a case of secondary hyperfunction where the pituitary is the problem, for example, it may be making too much of a stimulating factor like TSH or ACTH, then the pituitary hormone will be high and the endocrine gland secretory hormone will also be high, shown here. Now let's talk about cases of hypofunction. So these are patients who look like they have too little of some type of hormone, and when you measure that end organ hormone, it's low. So then you want to know, is it low because the gland itself is failing or because the pituitary is failing to send a signal? And so primary hypofunction means the gland itself is failing. And in this case, the pituitary gland, which is healthy, should respond appropriately. It should raise the level of the pituitary hormone, for example, ACTH or GnRH or TSH, to try to get that endocrine gland to function again. So this means that the pituitary hormone will be high in cases of primary hypofunction. In cases of secondary hypofunction of a gland that's controlled by the pituitary, both the pituitary and the endocrine gland secretory hormone will be low since the problem originates in the pituitary, such as a patient who has a pituitary tumor, for example.